Subcommittee will come to order. I think it's such an interesting season that we're in right now. And first, a word to the members, and then just a general opening statement. A word to the members is that we have so many meetings that I've been involved in over the past several years on healthcare have sort of a dour tone to them. It's looking out over a landscape that's challenging and difficult, and levels of frustration and this, that, and the other thing. I think today we have an opportunity to eclipse that discussion and have a different conversation, and to be a little more forward-leaning, and to be looking at things that are optimistic and buoyant and invitational as it relates to the healthcare discussion. And that's the purpose of us coming together today. Throughout the past couple of decades, we've seen innovation transform the way we look at healthcare technology and delivery. And in the Medicare program, many of these cutting-edge ideas have failed to be used to their full potential. In turn, our seniors haven't been able to benefit from greater efficiency, access, and increased positive outcomes in receiving healthcare. And even worse, while some Americans already have access to these groundbreaking models, when they're at risk of losing their pathway to receiving this care once they turn the age of 65, that's a fact. It's not out of line to say that we're missing an opportunity to save lives with these enhanced treatment methods. Today's hearing is the second in a series of looking at these innovations in the healthcare sector. We'll hear from witnesses on how they're disrupting the status quo by doing things that haven't been done before. These witnesses, appearing before the committee, have all in their own way looked at the current state of affairs and have said, we can do this better in various fields. Whether it's providing access to better, more holistic treatments, or increasing efficiencies that inevitably lead to lower costs, I'm pleased to hear from our witnesses on how they can help both improve and modernize the Medicare program and, in turn, increase its sustainability. The lessons we learn here will be on how Congress can help. Can we help both advance and expand upon these frontline advancements while also leading to a new wave of innovators unleashed on the status quo? In doing so, we can equip our Medicare beneficiaries with the tools to benefit from pioneer ideas. We need to start implementing policies that open the door to these potentially life-saving medical devices, drugs, and delivery methods in the Medicare program. It's well past time that our Medicare system was brought into this new century. Continuing to fiddle at the edges of an aging healthcare delivery model can only do so much, and we need to have different conversations about the transformations that are possible. And I think that's what today's hearing and today's discussion is all about. Now I'd like to yield to my friend, the distinguished ranking member, Mr. Levin, for the purpose of an opening statement.
Thank you, Mr. Chairman. Welcome. We're glad you're here, and we're glad we're having this hearing. As we discuss the issue of innovation, it's important that we not lose sight of the broader context in which we are having this conversation. Innovation should not be a scattershot assortment of new technologies or novel concepts that lack a connection to the overwhelming goal of improving quality and reducing costs. In order for this to be a worthwhile discussion, we have to emphasize a link between the new ideas that we are exploring and actions that will result in real improvements in the healthcare system. This is certainly something we had in mind when we developed the Affordable Care Act. Mr. Kind, who's here, Mr. Thompson, who will be joining us, were among those who joined together on this very, very important aspect. The Affordable Care Act was not only a landmark reform of consumer protections and historic expansion of coverage for tens of millions of Americans, it was also a huge step forward in how we deliver health care. The law placed a heavy emphasis on innovations that have moved us closer to a payment system that emphasizes value-based care. It facilitated the creation of hundreds of accountable care organizations, which have served as the backbone of payment reforms. In the past few years, ACOs, and other innovative initiatives established by the ACA have already achieved measurable savings and significant improvements in quality. The ACA also established the Center for Medicare and Medicaid Innovation, providing us with powerful tools to test delivery system reforms and new ways of paying for care. Under the Obama administration, the Innovative Center embarked on a number of initiatives that were reducing inefficiencies and holding providers in a variety of settings accountable for outcomes. This showed that the administration's commitment to innovation was backed up by meaningful actions and transformative reforms. However, the same cannot be said of this administration in our judgment. Last summer, CMS announced that it was pulling back from an innovative center demonstration that was testing value-based reimbursement for hip and knee replacements and an episodic payment model for cardiac care. Similarly, the administration also has abandoned Secretary Burwell's ambitious efforts to tie 90% of Medicare payments to value or quality by the end of 2018. And earlier this week, CMS issued a vague request for information seeking feedback on an ill-conceived direct payment contracting experiment that many seniors worry could undermine the Medicare promise. As we face growing challenges in healthcare, such as the continuing rise in prescription drug costs, it is incumbent upon the administration and us to show more leadership on these issues. But despite rhetoric and big promises, we have yet to see a focus on real innovation from the administration, CMS, or the Secretary of HHS. I hope that we can discuss these and other issues in more detail this morning and begin to explore a new path forward. Thank you.
Thank you, Mr. Levin. I'm pleased to introduce today's witnesses. First, we have Dr. Matthew Phillip, who's a physician at the Breakthrough Center in Wheaton, Illinois, and he's joined at the table by Dr. Paul Merrick, the president of the DuPage Medical Group. Next, we have Dr. Oliver Karaz, who is the chief executive officer and founder of ZocDoc. We'll hear from Dr. Becky Hafner-Fogarty, who's the vice president for policy and strategy at Zipnosis, Inc. And after that, we have Dan Paletti, who is the Chief Executive Officer for the Ohio Health Information Partnership. And finally, we'll hear from a familiar face in a different role, and that is Sean Cavanaugh, formerly of CMS, who's here representing the company, Aledade, as the Chief Administrative Officer. So, Dr. Phillip, thank you so much for joining us, and please proceed with your testimony. You're recognized.
Chairman Roscom, Ranking Member Levin, illustrious members of this committee, I just want to thank you for this incredible opportunity it is to be with you and share the innovation we're seeing in DuPage Medical Group, and specifically with our intensive outpatient care clinics that we have. I joined DuPage Medical Group in 2009 after completing my training in Northwestern University and University of Illinois in Chicago, and I initially started taking care of our hospitalized patients and focusing on their quality of care. And what we found is the same patients over and over were getting hospitalized, readmitted, going to the emergency rooms, and we wondered why this was. And so we looked into the data, and we found data from the Department of Health and Human Services that showed that 5% of patients accounted for a whopping 50% of healthcare costs. And this data was borne true in multiple different research studies. So we looked around to see what kind of compelling models there were that could address this urgent issue for our patients, and we didn't find anything that was compelling that could really move the needle on their care. So as an entrepreneurial, independent physician group, we decided to come up with a plan. And so we put our bottom line aside and we said, what can we do for our patients? And we came up with this model called intensive outpatient care clinics. And what that entailed was a team of people, which a physician, nurse practitioner, nurses, pharmacists, social workers, with resources such as labs, imaging, physical therapy. But more than that, we tried to create a holistic plan, as Chairman Roscom mentioned in his opening testimony, that was tailored to each individual. See, instead of putting patients into boxes and trying to fit them into a system, which didn't work, we tried to meet patients where they were at and remove some of the obstacles that were holding them back. And what we noticed is, whether it be the opiate crisis or mental health issues or a variety of physical conditions, and what we noticed were remarkable turnarounds in patients' health. Over the past 4 years, we've seen steady improvements in patients' quality, decreasing costs, and patients were happier that we saw this. In fact, last year we saw up to an even greater than a 50% decrease in hospitalizations, hospital readmission rates, emergency room visits, which is truly incredible. And this contributed to DMG, which is part of the Illinois Health Partners ACO, which is the 5th largest ACO in the country, having top 15% quality and bottom 28% cost. Now, while those stats may sound remarkable, I think what really brings us home and crystallizes this is actual patient stories, because when we talk about patients, we're talking about people. And one of the persons that I met with just this past week was Mr. T, who is a 71-year-old patient who is a retired military serviceman. And he had been seen in a local area private health system, and he transitioned to our care because he was really struggling. When he brought his records over, I looked through his records, and I noticed that he had seen over 10 doctors, and every 2 weeks he was in the emergency room or he was going to the hospital. Despite all of those health interventions and that cost of care, he was progressively getting worse. And his kidney function had progressed to the point of the stage right before dialysis. And when he came to me, he was frustrated. He was disappointed. He was ready to give up on the healthcare profession and just go on his own, as he said. But what we did is we said, let's start over. Let's just meet you where you're at. What is the problem? And we worked with him to figure out what the root cause of that problem was. And we realized we were way overcomplicating it. He was confused. People were just, they looked at him as just a body. And their solution to treating the body was more pills, more tests, more procedures. And he was frustrated by that. And what we did is we came up with a plan that was tailored to him. We decreased his medicines. We simplified his care. And what we noticed is he started getting better and better. He started seeing me 8 months ago, and over these last 5 to 6 months, he hasn't had one emergency room visit. He hasn't had one hospitalization. And more importantly, he's living independently in his own home with his wife. He's feeling better. He's going out to breakfast, and he's more engaged in his community, which is very compelling. And then, remarkably, his kidney function, which was bordering on dialysis, has started to improve, and his heart function has improved. This is just one of many stories that we have to say, and these are real people behind these stories. Again, as we heard in the opening testimony, there's so many terrible things that happen to people all the time. And we can be a part of the process, getting rid of some of those things, meeting people in the gap and helping them wherever they are, whether it be with opiates or mental health or their physical medical conditions. Now, while we're seeing that improvement in quality, we're also seeing top 1% Press Ganey scores for patient satisfaction, both in our region and nationally. And I would humbly submit to this committee that if we can improve quality while improving patient satisfaction, and if we could spend 50 cents on the dollar to do that, why wouldn't we look for opportunities to do that as much as possible? Thank you so much for your time and for this opportunity.
Thank you, Doctor. More questions for you later. Dr. Karaz, thank you. You're recognized.
Okay. Chairman Roscom, Ranking Member 11, and members of the subcommittee, thank you for the opportunity to testify today on how ZocDoc leverages technology to improve patients' access to care. When I founded ZocDoc in 2007, technology was just beginning to modernize the consumer experience across all industries. But healthcare was being left behind. The doctor directories provided by insurance companies are frequently out of date. And even a best-case scenario, calling down one doctor office after the other is inefficient and a frustrating experience. I knew that the status quo wasn't acceptable for patients. So I left my career at McKinsey, and I had the aspiration to create a service that actually delivers on the digital, seamless healthcare experience that patients expect and, quite frankly, deserve. Most people told me this just could not work. Healthcare is too antiquated, it's too fragmented, to be improved. But as a doctor, as a businessman, as a patient, I felt that healthcare is the challenge of our generation. If we don't fix it, it's going to break our health, or it's going to break the bank, or both, and neither of those are acceptable outcomes. Now, a decade in, ZocDoc's mission is to give power to the patient. Every month, we have 6 million Americans use the service across the country. And in the last year, we served 100,000 Medicare beneficiaries. Let me tell you how the service works. When a patient comes to ZocDoc.com or they use our free mobile app, they tell us the reason they want to see a doctor, their location, and their insurance coverage. We then show them in-network nearby doctors that meet their specific criteria. They can read reviews that have been left by other verified ZocDoc patients, and most importantly, they see real-time availability for this doctor. They can then make a choice between these doctors based on their own preferences and book an appointment with just a few clicks. This service is completely free for patients. Doctors pay to participate on the ZocDoc marketplace. Now, the results speak for themselves. On average, it takes in excess of 3 weeks to see a primary care doctor when you book over the telephone. In contrast, on ZocDoc, the typical appointment happens within 24 hours of booking. Now, how can we be so much better than the typical healthcare experience? Well, what we discovered is that while doctors are booked out several weeks into the future, they actually have near-term availability because of last-minute cancellations and schedule changes. In fact, 20 to 40% of doctors' appointment slots go to waste. We can make this hidden supply of healthcare available and bookable for patients in real time. And that, obviously, as discussed, has a massive and dramatic impact on their healthcare experience, but it also improves systemic inefficiencies. When you can take friction out of accessing healthcare like this, you actually promote these important preventative appointments that people just put off too easily. You also improve or avoid, rather, emergency room utilization. Think of a patient that has a severe flu and can book an appointment for the next morning at 10 p.m. at night. That's an avoided emergency room visit right there. And that's the most expensive venue of care you could pick. ZocDoc is the largest online health marketplace, and you can find appointments for over 50 specialties and nearly 2,000 different procedure types on ZocDoc. We work with private practices of all sizes. We work with large health systems and leading hospitals. And our technology comes with out-of-the-box interoperability with many of the 1,400 different scheduling systems and practice management systems that our providers use to manage their calendars. Now, our team continues to innovate every day, and I'm proud of what we have already achieved. However, we are far from done. Particularly when I look at our provider network, it's very robust in urban settings, but there is still work to do to give access to our members in our rural communities. This is a focus for me personally in the coming month, and we're looking forward to working with the committee to overcome the statutory and regulatory obstacles that prevent doctors in rural communities to participate in the service. Again, I thank you for the opportunity to testify today. It's an honor.
Thank you, Doctor. I'll now recognize Mr. Paulson for purposes of an introduction.
Well, thank you, Mr. Chairman. It's my pleasure to welcome with us today from Minnesota, Dr. Rebecca Hafner-Fogarty, also known as Dr. Becky to those who work with her. She is the Senior Vice President for Policy and for Strategy at Hypnosis, which is headquartered in Minneapolis. And in that role, she's been in that role since 2013 and also served previously as its Chief Medical Officer. Prior to that, she was the Chief Clinical and Medical Director at Strategic Alliances at Minute Clinic. I'm glad she's here to share some background and perspective and information about the great work that Hypnosis is particularly doing in the telemedicine space. They started with an idea that if we're going to move forward to a more patient-centered healthcare delivery system, then we should make it easier for patients to be able to access and use it. And Dr. Hafner-Fogarty and her team at Hypnosis are visionaries who have created a very intuitive platform for doctors to help see patients for a diagnosis quickly without having to leave their home, leave their business. And I visited Hypnosis several times. I've met with the employees. I've spoke with them about their work and the need for this type of innovative technology. We've seen their growth over the years. They are clearly a definition of a disruptor in innovation. I want to thank Dr. Hafner-Fogarty for being with us today and look forward to hearing her ideas as well. And I yield back, Mr. Chairman.
Thank you. Doctor, you're recognized.
Thank you so much. Chairman Roscom, Ranking Member 11, and subcommittee members, thanks for the opportunity to be here, and good morning. I've submitted written remarks, so I'll try to just hit some highlights during this brief time. I'd like to start with a short quote from one of my favorite philosophers, Kermit the Frog. Kermit tells us it's not easy being green, and in Kermit speak, to be green means to be different. Kermit's right. It's not easy to be different. However, by departing from the ordinary, all of us sitting at this table are positioned to make a positive impact on healthcare. In fact, I would argue that thinking differently is necessary to addressing the challenges that characterize today's healthcare landscape. Mr. Chair, if there's anything I'd like you to remember about my testimony this morning, I hope it's this. Zipnosis is philosophically different from almost every other telemedicine company in the country. As Representative Paulson said, our goal has been to transform healthcare for the better. And it's no accident that we are located in Minnesota. Minnesota's long been a hub of healthcare innovation, starting a few years ago with two brothers who started a little clinic down in Rochester. Part of that innovative spirit certainly belongs at the feet of our very enlightened state, local, and federal government officials. And I would like to personally take a minute to thank Representative Paulson. He's been a supporter of Zipnosis since it was about 4 of us sitting around a table in a coffee shop. So thank you for your support. Another key supporter of healthcare innovation has been Senator Amy Klobuchar. Zipnosis is clinically and technologically different. I won't get into the technical nuts and bolts here, but we are the first virtual care company to offer a truly multimodal platform. That means you can do an asynchronous store and forward visit, you can do a video visit, you can do a chat visit, all on an encrypted, HIPAA-compliant digital platform. Because we're digital, we can easily track every click that a patient or a provider makes, so it's very easy for us to audit our quality and make sure that the care that's being delivered is truly quality care. Another thing that makes us different is that we do not provide telemedicine care ourselves. We're a SaaS company. We license our technology to health systems. So being a family physician, I think it's important to recognize that if all politics is local, certainly all healthcare has to have a local base. So we make it easier for those docs to connect to their patients using technology. We just recently partnered with the American Academy of Family Physicians. This is a really groundbreaking partnership. We're designing a version of our platform that will make it easy for those small and medium-sized family practices, largely located in rural areas, to use the technology to make it easier for patients in their community to get access, to reach out to patients who don't have access in their community. I want to spend my remaining time saying that there are challenges to being different. Some of our challenges at Zipnosis are related to the fact that a lot of times, because we're chiefly store and forward, healthcare regulators don't know quite what box to put us in. There are also challenges inherent to telemedicine in general. A fragmented regulatory landscape where every state has multiple definitions of what telemedicine is and what the rules are. Reimbursement is another major factor. The AAFP tells us that that's one of the 2 major factors impacting the reluctance by physicians to adopt telemedicine, is they can't get paid for it. So that's where folks like you can help folks like me. Hopefully we can work together to improve both the nomenclature and certainly the reimbursement. Thank you so much for your time, and of course I'll be happy to take your questions.
Thank you, Doctor. Mr. Paletti, you're recognized.
Thank you, Mr. Chair, members of the committee. I appreciate the opportunity today. My name is Dan Paletti. I'm the Chief Executive Officer of the Ohio Health Information Partnership, which also manages the CliniSync Health Information Exchange in Ohio. This testimony is as much about technology as it is about community collaboration. We are a nonprofit 501c3 organization created in 2009 from the ground up by stakeholders from across the state who really felt that the need for a robust health information exchange infrastructure was key to lowering cost, efficiency, and providing better care. Ohio is a microcosm of the nation. We have a population of almost 12 million patients. We have 12 million people. Those people occupy farmlands, Appalachia, and multicultural urban centers in our major cities. The challenge of leveling the playing field around the technology first appeared very daunting, but a multi-pronged approach was implemented. We spent many years helping over 6,000 primary care physicians in collaboration with many community stakeholders to adopt electronic medical records, while at the same time putting in place the Health Information Exchange CliniSync, which was created in cooperation at first with hospitals throughout the state. We now have over 157 Ohio hospitals, many competing with each other in their environments, participating, which has created an interoperable environment for patient health information in Ohio. This approach has enabled the network to quickly become financially sustainable and resulted in a medical community that now electronically exchanges patient records instead of using paper. In Dayton, we've partnered with the Wright-Patterson Air Force Base, the Department of Defense, and the Wright-Patterson Medical Center to use the CliniSync services to enhance interoperability to help active duty members, the troops, their families, and their veterans, and we are currently testing with the VA. The philosophy in Ohio is that the record should follow the patient. The community health record allows authorized treating physicians to access a patient record no matter where they had care. To date, almost 13 million individuals have a community health record in Ohio, and the consent policy allows patients to be included unless they choose not to and opt out. Another important innovation enables notifications to physicians if their patients are admitted to an emergency room or admitted as an inpatient in discharge. These notifications allow for quick follow-up and intervention if care can be provided outside of the hospital. Since late 2016, almost 7 million notifications have been sent to providers. An example of notifications where notifications have helped with intervention was for one provider who received 3 alerts in the same day on the same patient from 3 different emergency rooms, indicating possibility of opioid addiction. These notifications allowed for proactive steps for action with that patient. University hospitals in Cleveland are working with dialysis centers in Cleveland to coordinate care of over 12,000 dialysis patients when they hit the emergency room. An alert is sent to the community nephrologist. They work with the emergency room to reduce some of the tens of thousands inpatient days that are accounted for by those dialysis patients. There are lots of stories I could tell you. We could spend a lot of time talking about innovation across the state, but I'd like to spend the remaining time just with a few suggestions on where you might be able to help. When it comes to innovation ideas, coordination, as CMS moves to alternative payment models, the importance of implementing efficient care and case management is critical. Look for those efforts that are already working. Telehealth and remote monitoring is key and continues to emerge as an important solution to hold the possibility to impact significant challenges such as cost and access. Quality reporting. In the past, payers have defined quality using multiple different metrics, resulting in a very expensive, burdensome, and unnecessary administrative task. Harmonizing those quality standards across the payers and providers is an important step. Behavioral health. There is a significant need to revisit rules allowing for data sharing restricted by CFR Part 2, CFR 42 Part 2. These patients have some of the most significant needs, and if they want their information to be shared, we should allow that. House Resolution 3545, Overdose Prevention and Patient Safety Act, that I know some of you are involved with, is a very important step forward. Primary care initiatives. Continuing to fund innovation that puts a primary care provider in the front has allowed Innovation Ohio to really move forward. And with that, I will pause and allow questions later. Thank you.
Thank you very much. Mr. Kavanaugh.
Thank you very much for inviting me here today. It's always a pleasure to be in this room. Not many people know, but I actually started my career many years ago as sitting in the back row there for a member of this subcommittee, so it's a pleasure to be here. My name is Sean Cavanaugh. I'm the Chief Administrative and Performance Officer at Aledade. We're a healthcare company that partners with independent primary care physicians to help them transition to and thrive under value-based payment models. Prior to joining Aledade last year, I served at CMS for 6 years, 3 years at the Innovation Center, and 3 years as Deputy Administrator and Director of the Center for Medicare. In those capacities, I supported the movement toward value-based models, and I'm proud to continue that work at Aledade. Aledade was founded in 2014 to help independent physicians transform healthcare. We bring together independent practices in a community, practices that are committed to value-based care. We help them form an ACO and join the Medicare Shared Savings Program. Then we ensure their success as an ACO by providing population health tools, data insights, practice transformation expertise. Finally, we negotiate similar ACO contracts with commercial payers so our physicians can transform care for their entire panel of patients. Aledade's grown rapidly. We now partner with 1,400 doctors and 247 independent practices, FQHCs, and rural health centers. These doctors are organized into 20 ACOs across 18 states, and they're accountable for 220,000 Medicare beneficiaries in the Medicare Shared Savings Program and another 90,000 patients through commercial ACO arrangements. More than half of our primary care providers are in small practices with fewer than 10 clinicians. And we're on pace to grow significantly next year and years to come. But most importantly, Aledade's producing meaningful results in partnership with our physicians. We've empowered our practices to deliver more primary care, and by delivering more primary care, they've reduced unnecessary hospitalizations across the country on average by 10%, and reducing post-acute care stays on average by 22%. And the data shows our results improve the longer our practices work with us. We're committed to using technology, data, practice transformation expertise, and most important, by emphasizing the relationship between a person and their primary care physician to improve health care. Medicare has been critical in this movement to value-based care. As was mentioned by Mr. Levin, the ACA created and funded the Innovation Center to test and design new payment and service delivery models. Congress reinforced the importance of the Innovation Center when it passed MACRA on a bipartisan basis. MACRA incentivizes alternative payment models, and the Innovation Center is the source of those alternative payment models. But the cornerstone of CMS's value-based payment movement has been ACOs. Nearly 10.5 million Medicare beneficiaries are in the Medicare Shared Savings Program alone. And we have strong evidence now, both from CMS's Pioneer evaluation and Harvard researchers, that ACOs reduce costs and improve quality. Importantly, the evidence also shows that independent physician-led ACOs achieve greater results than those led by hospital systems. Congress has done a lot to support value-based care, and we have some recommendations for additional things you can do. There's a longer list in my written testimony. I'll emphasize a few important ones. One, support competition in healthcare. You can do this by removing incentives for the merger of hospitals and physician practices. These mergers are often incentivized by facility fees for hospitals where those services can be easily provided in a physician's office. Sometimes those consolidations are incentivized by the 340B program, which we think and deserves some review, and we know that Congress is doing that already. Congress can prohibit anti-competitive behaviors such as data blocking. One of the frustrating things for us has been hospitals that aren't willing to notify our PCPs when patients have been discharged from the hospital. We welcome efforts like those in Ohio to make sure that happens. Specific to the ACO program, I think the two important things you can do and CMS can do is, one, provide more predictability in the benchmarks. The current benchmarking formula that determines whether an ACO has saved money or not is very complex. It's based often on national data rather than local data, and it's done retrospectively. I think you get more ACOs to move to two-sided risk if we move to something more predictable and well-known, something like the Medicare Advantage benchmarks, which are set prospectively. And then finally, make downside risk less risky. I think many of us would like to see more ACOs move to two-sided risk. CMS created Medicare Track 1+ last year, which calibrates the downside risk to make it strong enough to motivate behavior change, but not so risky to threaten physician practice's solvency. Thank you very much for inviting me.
Well, I want to thank all the witnesses. You've given great insight. You've got great backgrounds. We appreciate your written testimony very much. And now I'm going to invite our members to inquire, and we'll start with the gentleman from Texas, Mr. Johnson.
Thank you, Mr. Chairman. I appreciate that. Mr. Pawletti, welcome to the subcommittee. As you know, today many of our military service members receive care at both military and civilian facilities. For example, they may see a military doctor on base for a routine visit, but see a civilian doctor for another reason. I understand that you've been working closely with Wright-Patterson Air Force Base to coordinate care between military and civilian health care providers for active duty troops, veterans, and their families. As a 29-year Air Force veteran, I commend you for that work, and I want to ask you a couple of questions. One thing I'd like to know more about is whether or not the VA is working to improve their coordination of care with non-military folks like DOD has been doing with your organization. It's an important issue for our troops, veterans, and their families. Mr. Pawletti, can you tell me if your organization is currently working with the VA on coordination of care, and if so, can you tell me about those efforts and how many VA facilities you're working in?
Yes, Mr. Johnson, an excellent question. And as the only member in my family who's not been in the military, the male, it was important to many members that we work on that. We are currently testing with the VA at the national level. What that means is the interoperability between what we're doing with the private community-based providers in the VA will soon be interoperable. We expect that to be in place in the next 2 or 3 months. So the VA, just like Wright-Patterson Air Force Base, will be able to communicate and coordinate with all the local-based providers in the state. We have VA facilities all over the state, in Dayton, Columbus, Southern Ohio, Cleveland, and we're using national standards to facilitate that. Just as a note, we are also working with the different EMR vendors that both the DoD and the VA are looking at and implementing to make sure that the interoperability that we do now with them will carry over once they install their new electronic medical records. But that is critically important to care for our veterans.
And you haven't had any difficulty receiving that healthcare information?
Well, we're not in production yet, but in the testing we've had no problem. In the VA, the folks from the VA we've been working with have been wonderful and very, very good to work with.
Thank you, sir, and I yield back.
Mr. Levin.
Mr. Chairman, you started off by talking about optimism, and I very much share that. I must say that listening to the testimony, especially from a few of you, there's reason to be optimistic about the results of recent reforms and recent actions that we took. Mr. Pawletti, for example, in your efforts, did you receive federal funding?
Yes, sir. In 2009, our original funding came from the HITECH Act as the state-designated entity for health information exchange in Ohio. Since that time, though, we have not taken any more federal funding, but that did get us started.
The money originally came, I remember well, what was it, 10? How much money was it that we put aside? 10 million, I think.
The original funding into Ohio was $14 million.
Dr. Merrick, you're an ACO?
Yes, sir.
And that also was projected through the ACA. It's working?
Yeah, I think the important things that have happened as a consequence of the Affordable Care Act is healthcare is a team sport, and it traditionally was much more fragmented. and the move towards transparency of information and data collection to drive higher quality, lower costs has been a very positive thing. I think one of the challenges that we, as an independent doctor group, have experienced, one of the unintended consequences is there's such an investment required for EMR and all these other things that the independent physician is becoming more and more extinct because of the pressures towards consolidation that were referenced by Mr. Kavanaugh. Our goal is to help physicians remain independent, because the data is very clear that when physicians practice outside a hospital employment setting, the quality of care goes up and the cost goes down. And so our goal in being here is, so I'm a practicing urologist. I still do surgery and see patients and serve my group. My father was a 40-year practicing OB-GYN doctor who delivered babies born in Michigan, in Saginaw. He taught me to be a trusted advisor to our patients, and that's our goal for us collectively, the 700 doctors of us, to be trusted advisors. And if there's any way that we could serve your committee as a trusted advisor to help Congress help us take care of patients, that's our goal in being here.
Well, thanks. I mentioned earlier, Mr. Kind and I sitting here can recollect how many hours we spent around the table talking about ACLA and talking about change from fee for service to value-based. It seemed to go on endlessly, but it was important. So, Mr. Kavanaugh, let me just ask you, I don't mean to promote undue controversy, but I just don't understand this administration's position on the Innovation Fund. And for example, stopping an experiment which seemed to many of us to make so much sense. So why don't you comment on this? Because it's what we did in ACA was to provide some monies to try to cluster payments, right? So just tell us, you have about less than a minute, what's going on here?
Well, I appreciate the question, and I would start by saying Secretary Azar and Administrator Verma have said some very positive things about the value-based movement, and we appreciate that. I think what you're specifically referring to was under the previous administration, we had launched a model around some joint replacements and cardiac procedures. There seemed to be a philosophical objection to it because it was mandatory in certain regions of the country. The purpose of the Innovation Center, though, was to test models and evaluate them, and the reason that was made mandatory was we felt it was necessary for the evaluation, and that you wouldn't get sufficient numbers of participation in different regions unless you had required participation. So we were personally very disappointed that that wasn't continued. I thought it could have been very successful and paved a path for the program. And I'm sorry, the mandatory part became a stumbling block. But again, I would say otherwise they've said some very positive things, and we're hopeful they'll follow through on them.
Thank you. Thank you, Mr. Chairman.
Mr. Buchanan.
Thank you, Mr. Chairman. I want to thank you for bringing forth this folks here today, the witnesses, because in terms of innovation and moving forward, we all talked about delivering quality care, more affordable, but I want to focus on cost. Someone that's been in business for 40 years, 30 years before I've got here, and then obviously being here for the last 10, 11 years, I just see costs going like this. I see it in our area, bankrupting a lot of middle-class families where they've had to pick up more and more of the tab. I think of myself when first 20 years, we paid for everybody's insurance, family, no deductibles. Now the typical business might be picking up $700 in our area, and then the employees are picking up $700. It's $10,000 a year. I had an individual the other day tell me they got a restaurant, Italian restaurant in our area for the last 20 years. Him and his wife, they're in their early 60s because things are more age-weighted today. They're paying $3,000 a month. So it's outrageous what's happening. So That's why I applaud the chairman doing this, because we have to start looking for ways to be more efficient, bring better care, but we've got to start betting the cost on the cost of care. And we talked about that 8 years ago. There's plenty of blame to go around, but I don't see that happening. What I see it is continuing to rise. Even if you got Medicare and Medicare Advantage, that continues to go up in terms of seniors. I'm in Sarasota, Florida, so I care about those issues. But let's start with you, Dr. Phillip. You had said part of what your practice or what you're doing is trying to develop better care, and you thought maybe 50, I'm taking your quote, 50 cents on a dollar. Just tell me, what are you doing to bend the curve on cost? Is 50 cents on a dollar in terms of the way you're delivering medicine to patients, is that realistic? Are you really seeing those kind of results? Or what's your thought in terms of bending the cost curve?
Thank you for the question. I think it's actually remarkable the amount of costs you can take out of the system, especially when the costs are so focused on a small percentage of patients. If we can invest in those patients, those vulnerable patients, we can see huge decreases in the cost of the system. In the example I gave you, but there's so many more examples of patients that are Medicare patients who were admitted every month with all of these tests done in the hospital, and they come out of the hospital and they said, well, they told me it wasn't this, it wasn't that, it wasn't this. But I said, well, what did they tell you it was? And they're like, they didn't know, but it wasn't dangerous. And I think finding that root cause of the problem and helping people to be well with that holistic approach, there's incredible cost savings. I had a physician partner of mine take his wife to the emergency room because she was nauseous, and he got IV fluids, IV nausea medicines, and it cost him $3,000 with his deductible to do that. In our clinic, we give a bag of IV fluids, it would cost us $20. We give them that same IV nausea medicine for $20, and we don't charge the patient anything. And they get the exact same care for a fraction of the cost. That's why site of service is so key. To get the exact same service in the right setting, it dramatically changes the cost curve.
One other reality in our area, I read in the paper a while back, I share this because it was staggering to me, is the USA Today front page, 62% of Americans don't have $1,000 in the bank. I had to really think about that. And then the idea in our area, the deductible average, Blue Cross Blue Shield, $7,000, $8,000. So how do you have health care? Dr. Merritt, let me get your thoughts on costs and rising costs. How do we start to bend the curve on costs? You said your father, I'm from Michigan, so Saginaw, I know where Saginaw is, from the Detroit area originally. But what's your sense of what do we got to do to start bending the curve on cost?
The first thing that we did in our group was awareness. And when I came out, if I would do a surgery on a patient, I had no thought or mindfulness about whether or not I did it at the hospital, at the outpatient surgical center. The cost difference can be up to 65% there. I think identifying the high-risk individuals and preventing hospitalization through Matthew's program is important. But our site of service strategy extends. We have what we call immediate care staffed by emergency rooms. We have 6 sites that have 15,000 visits per site per year at an average cost visit of about $280. The average cost of an emergency room visit is about $2,000 plus. And on top of that, roughly half the people who come to emergency room get admitted, and there's additional cost and risk from that time in the hospital. So the right service done the right way at the right place is critical.
Thank you, Chairman. I yield back.
Mr. Kind.
Thank you, Mr. Chairman. Mr. Chairman, let me commend you for holding this hearing. It's kind of fun and inspirational to get a panel of witnesses here telling us what is working within the healthcare system. We ought to be doing this every week, in my opinion. But we still face challenges, and we appreciate your feedback here today. I know when Mr. Levin and I and others were working on the Affordable Care Act, it was with the goal of disrupting a healthcare system that was underperforming and taking us to a bad place. We were focused on a few key issues. One was the fact, a recognition that we were deplorably behind the times when it came to the HIT and the electronic medical record system, and we had to catch up in order to get the data to make good decisions with. We had to disrupt a healthcare delivery model that wasn't producing great outcomes. And then we needed to try to realign the financial incentives to go to value, quality, outcome, and away from the outdated fee-for-service model. And it's exciting to see a lot of these things starting to gain traction. But we didn't delude ourselves in believing it was going to happen overnight. I mean, this was going to take a lot of hard work and pushing the boulder up the hill. Mr. Cavanaugh, welcome back to the committee. You were situated at the Center on Innovation. In my opinion, I think it was one of the better things that we actually did in the Affordable Care Act, because it did act as a disruptor, new delivery system models, new payment models. What really jumped out, and looking over your testimony, both written and oral, was the fact that you are achieving tremendous changes in the post-acute care setting. Chairman Brady and I have been delving in this world. It's one of the areas we I don't think, did a very good job at trying to address or reform under the Affordable Care Act. You mentioned that the model you have right now is reducing post-acute care usage by, what, 22% or so? Are there any highlights or takeaways that we need to be aware of that enabled you to achieve that?
The first highlight is that it was data-driven, meaning it's not unique to Aledade. When you look at Medicare spending and how much it varies around the country, a significant part of the variation is around post-acute care. And so we knew as we went into different communities that that was an opportunity. But it's also an opportunity because there's better ways to deliver care. The patient would rather be in their home with the right supports. So it's just working, and sometimes in partnership with skilled nursing facilities and telling them, you know, we're not going to send you patients that don't need to be there. And getting them to understand that there's a new paradigm, that it's not about increasing utilization, it's about doing what's best for the patient. So just a relentless focus on what the patient actually needs and what's best for the patient, and not the routine of just routinely cycling people through institutions.
Yeah, when we've got time, I'd certainly love to personally follow up with you and get more details on how that's working, because I think it folds in nicely with what Chairman Brady and I have been kind of focused on here for a while. But another issue of concern that you raised, and this gets back to HIT and the whole meaningful use and interoperability that we're still having difficulties trying to implement, is the data blocking that you just mentioned. Well, why is that such a significant problem, and what is needed to overcome that?
So when I was at CMS, we created a code called Transitional Care Management, because there was evidence when a patient gets discharged from the hospital, if they're very soon thereafter linked with their primary care physician, there's evidence that they're less likely to be readmitted, better health outcomes, lower costs. So we created a code so the physician could bill for that type of management. And then we saw that the code didn't get used much. And I went out to physicians and said, why aren't you using it? And they said, because we don't know when our patient was discharged from the hospital. We don't have the ability. But with health information exchanges, often that's now possible, and that's part of what Aledade does, is we make sure our practices know your patient was discharged yesterday, call them today. But there are sometimes, in some locations, there isn't a health information exchange. And we reach out to the hospital directly and say, we'll tap into your system for our data. And it's appalling to me that some hospitals say, no, we see that data as a competitive advantage, and we're not going to share it with you. Where there's evidence that is better for the patient, better for the beneficiary, they're taking a competitive stance.
Yeah, we've had to overcome some of those difficulties in Wisconsin with the coalition, the Quality Care Coalition that was formed there. Dr. Becky, if I may, I'm running out of time, but first congratulate you in invoking Kermit the Frog. I think it's the first time in committee history where we got that philosophy thrown at us. That's great. But you mentioned in regards to telemedicine the difficulty of the multiple standards across borders in different states. I'm sure licensing plays into that as well. Are you recommending some type of national standard to apply, or best model that we can move forward on? What exactly can we do to address it?
Sorry, thank you, Representative Kine. You know, I spent about 15 years on the Minnesota Board of Medical Practice, and those medical boards believe strongly in that each state is unique, and so each state should have their own definitions. It's job security for me, because it just makes interpreting that information difficult. I truly believe that if we could come to a standard definition of what telemedicine is, what virtual care is, and what telehealth is, that could be applied in a regulatory fashion across the country, that would at least get all of us talking the same language, and would be a huge benefit from a policy standpoint.
Thank you. Thank you, Mr. Chairman.
Thank you. Mr. Smith.
Thank you, Mr. Chairman, and thank you to our witnesses here. Appreciate your insight and input. One area of Medicare very much in need of innovation is long-term care. And we know that Medicaid is the primary payer on nursing home stays, but Medicare is the primary payer on the large healthcare costs of this population, such as the tremendous cost associated with trips to the emergency room from skilled nursing facilities. And in fact, on average, 19% of hospital transfers originate from skilled nursing facilities. Approximately 1 in 5 patients admitted to a skilled nursing facility are readmitted to the acute hospital within 30 days. So studies have found promising results in the use of telehealth to cut down on these massive amounts of ER trips for our most frail Medicare patients, and instead allowing patients to be treated in their homes. Telehealth can allow providers to be with nursing home patients at the time of their emergency. The difference this would make for patients, especially in rural districts like mine, would obviously be tremendous. So I'm wondering, would any of you like to speak to the promise of this technology or other technology in long-term care? Yes.
Thank you, Representative Smith. I think it really is quite critically important in rural areas because a small long-term care facility may be located physically located many miles from the nearest hospital or the nearest clinic. One of the problems that we tend to encounter is the ability of the care providers to get reimbursed for this care. And I think as we transition to a value-based care environment, that will become less of a problem because we will be transitioning away from this need to be able to charge on a per transaction basis. But I think there's great promise in telehealth. I think the increasing ability of platforms like Zipnosis to link with and to take in objective data by linking with remote monitoring systems will only make that better. The other thing that is very important in telehealth is the ability to integrate those telehealth visits into the patient's electronic health record so that there is a complete record of what's going on with that patient. A great many telemedicine companies and telehealth companies do not do this. You have increased fragmentation of care. You got visits floating around out here in the cloud and not connected to the rest of the patient's continuum of care. And so that's something that I think is increasingly important to make sure that telehealth is part of a whole continuum of care and not this thing that's sitting out there by itself.
So what would you say is the barrier to moving in a better direction?
I think reimbursement is a barrier.
Okay. Mr. Kavanaugh?
Reimbursement's a barrier. The reason CMS and Congress have had such restrictions on telemedicine is the fear that it would be not used wisely, but overused. But if you can get more providers to move to two-sided risk models, meaning they have an incentive not to overspend, but to use it appropriately, then CMS can unleash, and they've started to loosen the rules on telemedicine, but only for providers who are on two-sided risk. So the goal for all of us is to make those two-sided risk models workable for providers so that we can take advantage of these technologies.
Okay. Anyone else? Mr. Palletti?
I just want to, Dr. Becky mentioned something that's very important, remote monitoring. So remote monitoring in coordination with telehealth and other technology is critically important. So you can monitor remotely EKGs, blood pressure, pulse. You know, instead of having a patient drive 40 miles to the doctor for those routine checkups, that remote monitoring can be very efficient, very cost-effective. I was talking to the CIO at the Cleveland Clinic yesterday about what they're doing there. Some very fascinating things in coordination with telehealth. Holds great possibility.
Very good. Thank you. I yield back.
Mr. Higgins.
Thank you, Mr. Chairman. Everybody talks about costs, and really nobody does anything about it, including my party. The Affordable Care Act was a start, but it didn't come close to really cutting the cost curve to the extent that it needs to be cut. The cost curve is about cutting the rate of inflation on an annualized basis for medical treatment, and we still pay more than any other country, and our outcomes are considerably less. The reason I bring this up is this is not an ideological issue. This is arithmetical. And the fact of the matter is the federal government, under Medicare, under the VA, under the Medicaid program, provides health insurance as an insurance provider for 161 million Americans. That's more than 50% of the population of the nation. That is a lot of leverage. And in any business, be it healthcare or whatever business you're in, it's all about leverage. And the biggest mistake in the Affordable Care Act, and I was here as well, was that there wasn't a public option. Because the public option was viewed not as a public takeover of medical services. Not one doctor would become part of the public sector versus the private sector. It's all about the insurance. But you needed a public option to provide a countervailing force to private insurance. For example, Medicare, 2% administrative costs versus private insurance, 30% administrative costs. That drives up the cost of health care for who? The individual and the federal government that's providing health care. 90% of Medicare patients today have access to a primary care physician and a physician specialist. So there's a wide level of acceptance regardless of what providers say. They complain about reimbursement rates from Medicare, but they all take it. Why? Because it's a reliable payer. High satisfaction rate among Republicans, Democrats, and independents for Medicare. High satisfaction rate over 90%. So why wouldn't we simply use the best public option that already exists? That's the Medicare program, to allow people between the ages of 50 and 64 to buy into Medicare at their own expense, thus realizing great savings. Because we all know from the most recent iteration of health care advanced by the majority in the House, the most recent iteration, who gets clobbered? The population 50 to 64. Why? Because insurance companies view them as a risk. So they have huge deductibles, huge copays, and huge premiums to the point that they can't afford health insurance. So there's an incentive for all of us to provide an option to the American people that would allow them to buy in. It wouldn't cost the federal government a dime. It wouldn't cost a dime. Just allow them to take advantage of the great leverage that the federal government already has. Mr. Kavanaugh, you're an innovator in the Innovation Center, or used to be, in CMS. Why are we not pursuing aggressively, clearly, and quickly a Medicare buy-in for those between the ages of 50 and 64?
So under the Innovation Center statute, it's not clear we could have done that. That was clearly about creating payment and service delivery models.
You know what, we're already complicating an already overly complicated situation. I understand that you can't. That's why we're here. Okay. That's why we're here. You know, as I said at the outset, the Affordable Care Act, Obamacare, call it what you will, was supposed to be a start to health care after 100 years of failed attempts by both Republican and Democratic administrations. So we have the ability, you know, prior to the enactment of Medicare in 1965, less than half of seniors had health insurance in America. There was a very simple reason for that. Private insurance companies didn't want to write a policy for somebody who was older and sicker. A good and generous nation responded to that by creating a Medicare program. Now, over 95% of seniors have access to health care. The 50 to 64 population today is what the Medicare population was in the 20th century prior to the enactment of Medicare. So I'm sorry to cut you off, but this is not your problem, it's our problem. And you know, when we overcomplicate something that is so really simple in terms of the leverage points that we have, we defer a solution to a problem that we all have an obligation to solve. I'll yield back.
Ms. Jenkins.
Thank you, Mr. Chairman, and thank you all for being here today. Mr. Paletti, I think your remarks offer real hope for the role of technology in improving health care in the United States if we work with the innovative private sector to find solutions to our common problems. I want to direct your attention to page 6 of your testimony, where you recommend areas of focus for the committee to consider. In particular, you highlight mental health and substance abuse. I've introduced a piece of legislation, it's H.R. 3331 with my colleague, Congresswoman Matsui, that would authorize a demonstration program to provide health IT incentives to behavioral health providers. The legislation would enable psychiatric hospitals, community mental health centers, and methadone clinics to purchase electronic health record systems. With that as a background, I just have a couple questions for you. First, can you tell us more about the need to improve care coordination for people with mental illness and addiction disorders? And do you see this technology, such as electronic health records, playing a role in reducing cost as well as creating better efficiencies in the Medicare space?
Thank you, Congresswoman. It is a critical thing to address. If you look at the cost of care, behavioral health, the activity that occurs in our emergency rooms, and the frequency of which that occurs, and also all the other problems that behavioral health causes in this country, we have to address it. And technology is important. There are a lot of behavioral health providers, a lot of mental health facilities out there that don't have some of the technologies they need to do the coordination. So I do believe that any assistance provided to them would be incredibly helpful. But I also want to stress that even if they have the technology, unless we do address the rules around the CFR Part 42, Part 2 restrictions, it's going to limit the coordination that can occur even if they have the technology. And as I mentioned, there is a resolution in place right now that would address that. Again, the philosophy should be if the patient wants their information shared, we should allow that. And by bringing the behavioral health community into the fold, I do believe you will see a great impact not only on cost, but also some of the other tragic events that we see occur across the country.
Okay, thank you. I'm also interested in your views about the role of health IT in battling the opioid crisis. For example, do you believe that e-prescribing can help us both prevent opioid addiction and enhance the quality of medication-assisted treatment?
Yes, e-prescribing is a very critical step. In Ohio, most of our providers are e-prescribing, although we do have a two-factor authentication method in Ohio for that, so it makes it a little more difficult. But the ORS database, the prescription monitoring database that's been implemented in Ohio, and the mandatory use of that system by providers when they're prescribing Schedule II drugs, we've seen a dramatic decrease in Schedule II prescriptions in the state. So making it easier for the provider to understand what the patient has been prescribed in the past, making that information more readily available is helping. We're seeing it help now, and it will continue to help in the future.
Okay, thank you, Mr. Chairman. I'll yield back.
Ms. Chu.
Mr. Kavanaugh, thank you for being here today. For this question, I'd like to draw from your prior experience within CMS. This past weekend, I, along with some of my colleagues on the Ways and Means Committee, heard from a number of companies that are working in the precision medicine space about difficulties they face when seeking CMS approval for the use of their products and methodologies in the Medicare system. I was so impressed by their innovations. They had unique products or treatments that were customizable based on a patient's genetic makeup, molecular diagnosis, specific imaging, or other aspects of a patient's diagnosis. While many of these precision medicine products are relatively new, they were able to be moved through the FDA's approval process rather swiftly in some cases because they received a special breakthrough designation. However, after FDA approval, these same companies are struggling to be approved by CMS. Every one of the companies said they had trouble getting CMS to understand the nature of their innovations. And I realize CMS has a very important role in financial accounting, but should there be more expertise in subject matter, could there be room for improvement in CMS's approval process, or is there something Congress can do to improve CMS's approval process?
Thank you for that question. Even apart from precision medicine, we often ran into questions about why something was approved in FDA and either wasn't approved or took longer for CMS approval. And I would just try to remind folks that the two agencies try to work very closely together, but they do have different guiding statutes and different criteria. So the first thing is FDA approval is subject to one set of standards. When something gets to CMS, it's really going through three processes. A coverage question, is this something appropriate to the Medicare medically necessary for Medicare population? Coding, which is an intricate set of rules. Is it unique enough that it deserves its own code? And then what's the level of payment? So as far as the precision medicine ones you're talking about, it'd be interesting for me to know which part of that coverage, coding, or payment they're getting held up in. But your general point is well taken. When I was at CMS, we cared greatly about fostering precision medicine. We tried to work closely with our FDA colleagues, but certainly the agency could always use more expertise and guidance from Congress in this area. It's tied into this theme of this hearing in that you want to make sure that these are truly innovative, meaning they improve quality of care for beneficiaries and/or reduce costs. I think that's the viewpoint that CMS has long taken. So I welcome your attention to this point, and I think my former colleagues at CMS would as well. My sense was they very much support these innovations and would like to see them through the process.
So that's why I'm thinking if we had more expertise on the review teams so that there could be better communication.
Certainly, and as I said, my colleagues worked very hard to work closely with FDA and make sure they had common understanding of technologies. I'm sure processes can always be improved, but that we understood that was important.
Okay, thank you. And Dr. Karaz, I was so impressed by what you're doing with ZocDoc. It certainly takes care of the last-minute cancellations and makes a doctor's time more efficient. But my question has to do with language availability. My district in California is one of the most diverse in the country. We have a population that is 26% Hispanic and 37% Asian. And this diversity is something we're very proud of, but it comes with certain challenges when it comes to healthcare. Specifically, there's a substantial number of my constituents who are limited English proficient or LEP. And in the US, 25 million individuals are LEP. 26% of the total Los Angeles metro area is comprised of LEP working age individuals. Furthermore, 47% of adults who speak Asian or Pacific Island languages are limited English proficient. So managing your healthcare can be difficult enough in your own native language, let alone in a secondary language. Can you talk about the steps ZocDoc is doing to make sure that there's language availability for others for whom English is not their primary language?
Absolutely, thank you for the question. And as a fellow American whose first language isn't English either, I understand the challenge. We have taken great care that discoverability of doctors that speak your language as a patient is one of the key features on ZocDoc, and we allow patients to identify doctors that speak one of more than 100 different languages so that they can ideally communicate it in their native tongue.
Thank you. Mr. Marchant.
Thank you, Mr. Chairman. One of the big hospital groups in my district is Baylor Scott & White, and I know Dr. Fogarty that Hypnosis has a relationship with them. Is that correct?
It is.
Could you explain to me just in a very fundamental way what your relationship is with them? What do you do for them? How do you get paid? And how does a patient know that you're in the process?
We have partnered with Baylor Scott & White for going on 4 years now, and the Texas telemedicine regulatory environment was very challenging when we first entered into partnership with them. So we started, what we do is we license our software platform to Baylor Scott & White. They create a site within their patient portal called Baylor Scott & White eVisits. So if you are a Baylor Scott & White patient and you would like to do an eVisit, you can enter through the patient portal, and you're given information about the eVisits. We ask you, why are you here? What's your problem? And then you are guided through an asynchronous adaptive interview. And that's a lot of adjectives, and what it means is you answer a series of questions that are identical to the questions I would ask you if we were sitting in an exam room together. And the questions change, the software changes the questions based on your answers. So at the end of this electronic interview, your information is submitted to a Baylor Scott & White physician, not a physician sitting on his deck in Malibu drinking a latte who happens to have a Texas license. It's a Baylor Scott & White doc who has a practice in your community. And the physician reviews that information, comes back to you and says, here's a diagnosis, here's a treatment plan, and if a prescription is indicated, we have a very novel e-prescribing function where all the physician does is enter the prescription. The prescription is actually filled because we allow you to pick the pharmacy that's most convenient for you. You're mobile, you're on your way to work, you're dropping kids off at school or daycare, so you may not want to use the same pharmacy every time. The record of that e-visit is then deposited within your Baylor Scott & White electronic health record, so the next time you walk through the door of a Baylor Scott & White clinic to see your family physician or your internist, he or she can see, and they can say, oh, Mr. Marchant, you had an e-visit here 2 weeks ago for a sinus infection. How are you doing? Did that clear up for you? So that's probably more than you ever wanted to know.
No, it's really very helpful. As a Medicare, I'm on Medicare, so how does a Medicare, when does it tell you we can't help you, or you need to go see the doctor, or your payment method? I mean, does it screen your payment method before it gives you any information?
We have the ability to, we work with an organization called Pocket Doc that creates eligibility files. So if you are a Baylor Scott & White employee, you belong to what we call a ZIP group, and that payment and billing is coordinated through Pocket Doc with the insurance company. Every single clinical condition that we treat has a number of automatic stop signs. So if you start a visit for bronchitis and you, in the course of our interview, tell me that you have shortness of breath and crushing chest pain, the software stops the interview right then and there because you're not medically appropriate to be getting your care by telemedicine. You need an emergency room. And part of the beauty of our relationship with Baylor Scott & White is we give you the next most appropriate site of care within the Baylor Scott & White system. We don't just tell you to go away. We say, here's the next step, and we can actually send that information forward.
Does Baylor Scott & White, do they use you because they're trying to keep people out of the emergency room or out of the, certainly not the doctor's offices, but do they try to drive traffic to this site? Is this a proactive program, or is it a program they just offer?
It's a proactive program, and initially they started with their employees. It might or might not surprise you, but people that work in the healthcare field are heavy utilizers of health care. And providing care for their employees was costing Baylor Scott & White a lot of money. And so they put us in place first for their employees to give their employees a lower cost option to going to the emergency room or going to urgent care. And, you know, most people just, they don't like sitting in the emergency room.
Thank you. Mr. Paulson.
Thank you, Mr. Chairman, and thank you also for having Dr. Hafner Fogarty here with Hypnosis from a Minnesota perspective. This has been great testimony to hear from all of you. Dr. Hafner Fogarty, let me ask you this question. You mentioned Baylor just a little bit ago, but what's the general makeup of the healthcare systems that Hypnosis supports? Are they big? Are they medium? Are they small? Is it across the gamut? Give a little perspective of that other than just Baylor.
Baylor Scott & White is one of the bigger ones. The smallest system that we have right now is a critical access hospital in central Minnesota that has 6 doctors and I think 6 nurse practitioners. So we are pretty size agnostic. We're really excited about this opportunity with the American Academy of Family Physicians to make a version of our platform available to those docs in 2, 3, and 5 doctor practices, because they need the technology almost probably more than the bigger health systems do.
Sure. You know, and one of the chief, complaints that I hear consistently from the doctors that I speak with on a pretty regular basis is the time they don't get to spend with their patients. They do a ton of paperwork, the compliance costs, and it's just taking away from the doctor-patient relationship. How does some of the platform and practice work now with Hypnosis, how does it change that, or what does it do with that doctor-patient compliance paperwork component?
Normally, a patient, if a patient and I are sitting in an exam room, I'm doing the data entry and all of the documentation. And I jokingly tell people I went to medical school because I couldn't type worth sour apples, and focusing on a computer keyboard is not why I went into medicine. What Hypnosis does is we shift the data entry to the patient. The patient creates the information. Our software translates that into a physician-friendly SOAP-style note that all doctors are used to reading. And when the physician makes the diagnosis and the treatment plan, the software creates the documentation. So our physicians literally spend 2 to 3 minutes on a telemedicine visit, and it really streamlines and makes them more efficient. And they're not going back for 2 to 3 hours at the end of the day doing work after work, which is something my colleagues who are still in practice do complain about.
Well, I know we're going to continue to need your advice. You talked about thinking differently, being green, but clearly that's going to be necessary if we're going to address a lot of the healthcare challenges that we all want to, I think, across the aisle work on. And healthcare regulators, as you mentioned, they don't know what box that telemedicine may have to be put in, or that Hypnosis or some of the other companies have to be put in. So you got a very fragmented landscape that is preventing the opportunity when you're delivering to patients now. Once they hit 65, once they hit Medicare, you may not have access as patients to a lot of these platforms. Let me just follow up. Dr. Phillip, I want to just ask you a quick question, too, in my time that's remaining. You talked a little bit about sort of the effort you have with an intensive team-oriented care model that meets some complicated needs in a very fragile population. I think of Medicare and a chronic care initiative that I had introduced bipartisanly with Senator Wyden and some others a few years ago that we continue to advocate for. And it's this coordinated care, because it sounds like this is a coordinated care model you're using. I think of Medicare having 68% of beneficiaries now with 2 or more chronic conditions, very different than when Medicare was set up in 65 as an acute care program, and that's consuming 93% of all costs. Is this kind of a similar component of or perspective of what you're doing? It's coordinated care, so the physician and the specialists are communicating, they're talking to each other, they're caring for the patient, and then in essence, we got to transform the system so you're rewarded for hitting benchmarks or caring for the patient as opposed to just sick care. It's more well care, health care.
Exactly. Thank you for the question, Congressman Paulson. What we find is that when patients are seeing 10 different doctors, they're getting 10 different stories, they're getting confused, that even if the doctors are seeing what everyone else is saying, they always think their organ system is the most important. You know, there's the old saying, if you're a hammer, the world's a nail, you know? And what we do is we partner with our patients and we kind of quarterback the situation. We say, okay, that physician-patient relationship is key. Let's create a plan together, and I will interface with each of the different the specialists on the case, and we'll chart a course together. And so that coordination of care is absolutely key. Because if there's no vision, what happens is a patient will see one doctor, they'll create a plan. The next doctor will change that plan. Patients get completely confused. Mm-hmm. And as we're adding more and more layers of service, this is critical to streamline and simplify care.
Yeah. Thank you, Mr. Chairman. Go back.
Mr. Kelly.
Thank you, Chairman. And thank you all for being here today. I think the chairman, since I've got on this committee, we have these Jerry Maguire moments where we're asking, help us to help you. And I think today is really a good example of that, and thank you, Chairman, for doing that. And I'm always fascinated when you all come in to talk about something that you know an awful lot about, or you know everything about, and we know so little about, but yet we're going to try to develop policies that are going to work with you somehow. And so I always go back to my private sector life, and I'm an automobile dealer, and one of the things that I marvel about is the data that we can collect and the data we can share, and in some cases, data that we can't share at all, whether it has a proprietary value to it or there's a privacy issue. I just want to bring this up, and this is what makes it hard for me to understand. General Motors recalled 8.5 million vehicles because of an ignition problem going back to 1997 and 2014. Now, it amazes me that we can contact sometimes second, third, and fourth term owners of a vehicle because of a serial number, but we can't talk to each other about private information that may keep people alive. So, in a Jerry Maguire moment, and Mr. Kind and I have something called the Healthcare Innovation Caucus, and I think it's great that we have a caucus, but in addition to just having a caucus, I want to have a caucus where we actually talk to the people who know innovation and know how innovation could help them, to help us develop policies. I think it's nice to have it on your card that you're a member of that caucus, but I'd rather go out of here with not being a member of a caucus, but actually got something done. So, want to help us to help you. What could we do from where we sit to make it easier for you to do what you are doing right now? And this idea of somehow, I mean, you can call a restaurant and make a reservation and say, I'm sorry, we're booked, to say, well, I really wanted to come. Say, well, you know, we'll put you on the list, and if somebody cancels, we'll call you up. I've never had a night yet where somebody didn't call up and say, you know what, got an opening, and we need you to fill that table, because it's all about table turn. So, how can we do this? What can we do? And I don't care, any of you weigh in on it, and if we don't get it done today, keep coming back to us. This chairman is dedicated to the idea that somehow we are going to make a significant difference in the way we deliver health care, and affordable and sustainable health care to the American people. So any of you that want to weigh in, and you all have a depth of knowledge on this.
If I may, thank you so much for the question. I think there are very concrete steps that you all could take to help Americans to go see the doctor when they need them, keep them out of emergency room, give them access to telemedicine. One of the things that is holding us back specifically is the anti-kickback statute of 1972 that hasn't been updated to keep pace with technology and what technology can do. And specifically, in order to be compliant, we are limited to charging all providers for a flat fee for participating on the ZocDoc platform. You know, that fee can have no relationship to the number of or value of appointments that they are receiving. That creates challenges, in particular for rural providers and small practices, because they have to take on the entire economic risk of participating on the platform. You know, we would like the flexibility to create a pricing model that includes a per booking charge. You know, this way we would be able to serve a much broader set of the U.S. population, particularly in rural areas. I recognize that the anti-kickback statute has, of course, important protective regulations for federal healthcare programs in this, but in my view, as long as the patient and not ZocDoc makes a decision for a doctor, these protective provisions in their spirit can be upheld.
Any of the rest of you, because you're dealing with this every day. Dr. Becky.
So one of the things that I really feel strongly about is I think we need to streamline, especially the Medicare rules around telehealth and telemedicine. Last week, there was a study that came out that said 31% of CMS telemedicine visits were improperly billed. Well, you know, if you're a provider, and you're trying to take care of patients, and you want to bill Medicare for a telemedicine visit, you have to be in a health professions shortage area, or you have to be rural, or you have to be in a Medicare Advantage ACO, or you have to be a next-gen ACO. And when they went back and audited all of those, that 31% of those misbilled visits, what they found was 90% of those misbilled visits were purely honest mistakes because the doc was a mile too close to a major metropolitan area and they weren't rural enough, or that was a major problem. So the best thing you could do for telemedicine, in my book, is to remove the originating site restrictions. Those are a holdover from the days when telemedicine was a doc-to-doc consult between a specialist in a metropolitan area and a primary care doc in a rural area. People are using their smartphones, and my 80-year-old neighbor uses her smartphone to do a telemedicine visit. So let's make it easy for patients to do it, and let's make it easy for doctors to get paid for doing it when they meet the standard of care.
Yeah, well, my time's up, but real quickly. If you can keep with us and let us know what it is you think we can do, why you think we should do it, and then how we can do it, that what, why, and how is critical, but keep sending it to us.
Thank you.
Thank you.
Just a warning to the witnesses. You give him eye contact, he's going to put you in a car you can't afford, but you're going to feel good about it. Mr. Meehan.
Thank you, Mr. Chairman. Don't know how to top that one. And thank you for this panel, which is really on the front lines of the innovation, such an important area. One of the realities is when you're back here in the end, somebody always jumps into the question you wanted to ask. But I don't think we really explored it thoroughly enough. Dr. Zraz, you mentioned it. We have been working very, very hard in looking at the anti-kickback and the Stark statutes as things which meant we're well-meaning at a particular time in medicine, but we're watching now as you are innovating. We've talked to docs who have, in their particular nature of their practice, much of what we're talking about today is how you're using technology to drive this work towards value-based care and greater innovation. Can you talk more specifically about how Stark and anti-kickback may be impediments to the use of your technologies that would allow us to give greater value-based care at a greater, lower cost?
Yeah, greatly. I think access is one of the key components to make value-based care work. ZocDoc is an access mechanism that is used broadly, for telemedicine and in-person visits today. The reality is that the anti-kickback statutes are, very constricting for the type of pricing models that we can put in place to allow our physicians to participate in the system and open up their schedules to patients. These mechanisms essentially put undue risk on many small practices and rural practices that quite frankly don't have the cash flow to make these bets, and we would like to take on this risk for them and allow them to pay in a more value-based format. This, given that the entirety of how the assignment works on ZocDoc is patient-directed, similar to the smartphone example we just heard about, does not create perverse incentives. It's patient-directed. The patient makes all the decisions. Everything that they see is around the patient's preferences. So we're just enabling the patient to do something that they have done traditionally over the phone. And it's not as if a heavy user of a phone line necessarily has to pay all the future calls up front and take the risk that no one calls.
Thank you. Sean, you have a thought?
Yeah, I just wanted to note that the anti-kickback rules that are referenced, the limitations on telemedicine, these are all artifacts of a fee-for-service system where, all right, the incentive is to do too much. How do we put guardrails around people doing too much? If you can get health systems, physicians in a value-based model where they're actually accountable for total cost of care, most of these concerns should fall by the wayside because they have no incentive to overuse care. But that's the challenge. How do we get them to be truly accountable for total cost of care. We have many ACOs in one-sided models. We need to and not just ACOs, but we need to transition so that physicians, hospitals are willing to take some downside risk, be accountable, and we can not worry about these antiquated laws.
Well, a lot of the times you're talking about where, when you say two-sided risk, that's where there's going to be a payment and you both work on trying to drive value so that you can take advantage of whatever efficiencies you can put in there. Is that right?
That's correct.
Okay. Would you talk to me about one other issue that we've got a problem that you've mentioned? It's the proprietary stake everybody seems to have. How do we get beyond this situation where somebody says, well, that's really good, but my hospital groups use this information system and we can't make those two things merge, or we're not willing to make them merge? How do we play a part in moving beyond that?
I think to do what you members of Congress do best, which is to think about the patient before you think about the hospital and the doctor. What is best for the patient? And that's why I actually applaud something CMS discussed yesterday. Administrator Verma said, some of this data blocking, maybe this should be a condition of participation in Medicare, because it's bad for the health and safety of a patient, for the patient's PCP not to know that you were discharged from the hospital. So yeah, you may think this is valuable proprietary data, but it's hurtful to the beneficiary. So we might make this a condition of being in Medicare. I think as long as you take a beneficiary perspective, there are ways to get there. It's when you step back and think of these as business models that's where we get into trouble.
Yeah, sort of the record follows the patient and you go from there. Thank you for your work. Thank you for your testimony.
Mr. Schweikert.
Thank you, Mr. Chairman, and thank you for letting me sit on the committee. I'm actually not on this one, but I pestered the chairman over and over and over to have a conversation with innovators, though my passion is, you're all innovators, where's the next level of actual disruption? And I want to set this for, over the next 10 years, 2/3 of all the growth in spending here in Washington is functionally Social Security and mostly Medicare. And if you actually look at our 30-year chart, $82 trillion in borrowing, not adjusted for inflation, solely Social Security and Medicare. The rest of the budget's actually in balance. Our baby boomers consume everything, and I'm one of them. And we seem to have this delusion of math, and the math will always win. We need a revolution in our healthcare costs, yet this morning, Wall Street Journal has an article of some of the new genomic personal design medicine, $1 million per cancer patient. So at one time, you're starting to develop technologies and mechanisms. I need the next revolution. How many of you enjoyed your weekend experience at Blockbuster Video? Things change. We need that disruption. And the fact of the matter is, my wearable that talks to my phone, that I come home and my pharmaceutical is already there, because we see the data on certain algorithmic health from certain types of body sensors being more accurate than a human. And I know that's uncomfortable. Forgive me for saying it this way. Dr. Becky, you're the only one who I've actually heard talk about some of the barriers out there. I have a fixation that portable medicine, whether it be the medical records, my in and out, have I been discharged, my being portable with me, but also my telemedicine being in some ways global and crossing state lines and breaking jurisdictions, if it's going to be efficient and accurate and robust. What are the barriers that you're coming up, either from licensing boards or medical practices or hospital systems? What do we have to break down to bring that revolution?
I have an ongoing, thank you, Mr. Schweikert. I have an ongoing conversation with my colleagues at the Federation of State Medical Boards about the need to look at how we regulate the practice of medicine in an era when neither doctors nor patients are constrained by geography anymore. And this notion of state-based licensure, and I'm committing heresy here by saying it, I think we have to look at making that much more universal and much more uniform across the country. I think that the tradition that the practice of medicine occurs where the patient is creates great difficulty and limitation if you're a physician who wants to use telehealth to treat patients in multiple states, because then you have to go to the bother and expense of getting multiple state licenses. I think another significant barrier is the ability to rapidly scale much of the new technology in a way to put it in the hands of lots of patients. Because if you have this cool thing that allows you to take a picture of your kid's eardrum and send it to the doc, unless you have 10 million of those in the hands of the parents of 10 million toddlers, those parents are still taking that child to the ER in the middle of the night.
And that's part of
new technology.
and that's substantially our fault in the way we compensate, the way we reimburse. When we see data that says 95% of emergency room visits were not necessary, there was alternatives paths. When we see the material science now saying I have something I can blow into that tells me I have the flu. And I know we only have less than a minute, and this is a brutal question, but for everyone on the panel, what is the technology disruption you see coming that both scares your business model, but you're optimistic for our society? What do we need to see?
I think versions of telehealth are going to be very important. At home monitoring, genetic testing, things like that. We're in the process of trying to recruit a very high tech savvy individual to help us meet patients in a virtual way. So, the idea of driving from your home, even to a doctor's office, but certainly not a hospital, to receive care, that's going to become antiquated. And I think if you fast forward 10 years from now, about 38% of our healthcare spend is in the hospital environment, and hospitals absolutely, unequivocally need to reinvent themselves. That should not be the point of service and care. It's the most expensive, inefficient delivery model.
And a huge debt load. Dr. Phillip.
I think we also have to marry technology with the patient-physician relationship. I was taught in medical school that 85% of diagnoses are happened by just listening and talking to patients.
What do you see as the technology that you hope or you see on that does what you need?
Yeah, I'm seeing a lot of wearable technology that could potentially help with that. I mean, I'm seeing people at home checking their weights with their congestive heart failure, that as their weights are rising, before they realize there's a problem, we'll realize there's a problem, and we're seeing that. Automatic blood pressure checks. Wearable technology would report their heart arrhythmias, their blood pressure, without them even realizing it, and we can prevent it.
Excellent.
I think the big challenge for us is going to be discoverability. Using the earplug example for a second, patients don't know about this, and as they enter a request in, we need to educate them that this is available. Telemedicine is something that has high demand on ZocDoc. However, nearly no one types in telemedicine when looking for this. They look for care the way they have always looked for care. We educate them in the moment that telemedicine is available, and then they can use new modalities.
The hospital as we know it is obsolete.
You could just stop right there.
The hospital as we know it is obsolete. The ability to use this computer that we call our smartphone to gather objective data about our blood sugar, our cholesterol, and all of that is...
The contact lens that does blood glucose.
Absolutely. What we need are platforms that organize that raw data into information that the clinician, the physician, can use to make clinical decisions about diagnosis and treatment. Because I don't want my patient sending me 50,000 automatic blood pressure readings. It's data overload. And so designing the systems that curate that data into usable information is absolutely critical.
Okay, the algorithm. Dan?
This may be a little bit scary with all the cybersecurity issues we've had recently, but I believe it's really around data, not so much the technology. Data around the patient is going to initiate proactive case management and intervention and dramatically affect the way that we deliver care.
Mr. Kavanaugh, and once again, Mr. Chairman, thank you for your patience with me.
We are partly a technology company. All the technologies that have been described are incredibly exciting. I think, though, I'd like to bring it home, which is these technologies, I have faith they will be developed. Whether they'll be productive or not will depend on whether they're supporting a patient and a physician, a primary care physician who stays with the patient, maintains a relationship over time, particularly as you said, we have patients in Medicare who've got multiple chronic diseases that are going to be in the program for many years. So the management of those multiple chronic diseases in that relationship between a patient and a physician, but augmented by technology, facilitated and made more efficient by technology.
Thank you, Mr. Kavanaugh. Mr. Chairman, look, I don't know if I can own the copyright on it, but I believe we're on the cusp of something we will refer to as digital pseuticals. The algorithm, the wearables, the management, and then platforms that analyze it and then say, doctor, you have a patient with this, patient, American, you have this, stop eating that. But if we don't have this disruption, understand, we're about to hit a financial cliff and it's coming at us fast. And I'm terrified we're not pushing hard enough for the disruption. Thank you, Mr. Chairman.
Well, on that happy note, let me, first of all, thank you. Look in my eyes. Thank each one of you for your testimony today. Just got a couple questions to kind of close us out. Mr. Kavanaugh, you said something that was interesting. I just want to get a little bit more feedback in terms of the condition of payment. In terms of condition of payment that would precede the sharing of information, how would that, what's the best next step on that, do you think? I mean, that, we're all motivated by different things, and that as a prelude, that changes behavior. What do you think? You've been on this side, you've been in the administration, you're in the private sector now. What's the best next step for that to happen?
So, as I said, there was a request for information out of CMS and Administrator Vermer yesterday that seemed to indicate that they were entertaining the idea that sharing information about hospital discharges and ED visits would be a condition of participation in Medicare. I think they could do it through regulation, so Congress wouldn't need to do anything. I think there are some technical questions. If there isn't a health information exchange, how does the hospital do it? But thanks to Congress, 95% of American hospitals have certified EHR technology. They can do this. It's all a question of will. And as I said, it's a question of whether they're willing to put the beneficiary first, because the literature's out there. It is good for patients to have their PCP know they just came out of the hospital.
So let me press it a little bit further. Is it good for patients to get the data themselves?
That would be fine. First of all, yes.
What would that look like? Is that pie in the sky in your view? Is that a bridge too far? Or is the technology, if I'm a patient at the DuPage Medical Group, which I am, by the way, violating my own HIPAA situation. But if I'm a patient at the DuPage Medical Group and, they're pushing to me, whatever it happens to be as a condition of payment, that's a good thing.
Absolutely, and I think at all times the beneficiary owns their medical record and should have access to it in any format that they can take.
Right, but the ownership interest is, your point is that the ownership interest is kind of in name only right now. Yeah, you own it, but good luck trying to mine this.
Yeah, and the question is it the beneficiary's responsibility? Like, the caregiver is the hospital, the caregiver is the PCP. They're the ones that should communicate and say, your patient was here and you need to know that.
Okay, that's helpful. Dr. Merrick and Dr. Phillip, one, part of we spent a lot of time talking about technology, but we're also here talking about practices and the disposition with which you're approaching patients and so forth. And so one of the things that made such a strong impression on me when I came to visit you, Dr. Phillip, in the practice in Wheaton was just a different disposition and a different feel to how you were interacting. One of us said, either you or I said, this is like the TV show Cheers, where you come in and people say, Norm, and your patients, you're happy to see them. Patients, you were telling me, like, stop in, and you didn't say it this way, but you can't get rid of these people because they're finding so much love and energy and joy and so forth. Can you speak to that? Because that's different That's unique. I get in and out, as you can imagine, of a lot of medical facilities in this role, and walking in, it felt qualitatively different. There was just a different vibe that was going on at your clinic. And it wasn't all technology, it wasn't all process. There was a different feel to it. So can you give me a sense of, how it is that the leadership at DuPage Medical Group values this and empowers you and so forth? And what is that, what is that like?
First of all, thank you for the question. That's actually one of the key things that we see. At the risk of sounding, not fancy or like a simple, physician here, it's the foundation of what we're talking about. This is wisdom of ages that we see, that caring is good medicine, that compassion actually works, that humility has an impact. When you marry that with research and technology, that's a really powerful combination. And what we see is, yes, patients do come. There is that kind of trusting interaction, which helps us to wean people off opiates, where they know that we do care about them and that we're not trying to torture them, we're trying to help them. And then they see, yes, their pain will get better. We're realizing that research out of Brigham Women's Hospital shows that the number one factor that increases life expectancy, the number one factor is actually social interaction. And the variety of social interaction we have is one of the biggest things we can do to increase our quality of life, our length of life, while decreasing our costs. And we use that and the resources that people have in their relationships, whether it be their local faith communities, their families, their friends, to say, hey, can we work together on this instead of just putting all the pressure on patients? We're realizing people come in incredibly burdened. Every day I see people burdened by the weight of healthcare. I'm not here to add more burdens to them, but to take away some of those burdens. That's powerful. These are things, again, they're not as fancy, but married with technology is incredibly powerful.
And there's a spiritual element of this, right? So if people come in and they want to be prayed over or they want to pray with someone, you're doing that, isn't that right?
What we see is that faith is incredibly important, regardless of your faith. Research shows that even if you're an atheist, that if you have faith in the medical profession, that creates something called a placebo effect, and we always control for that in all of our studies. That whatever it is that motivates people and helps them, we want to use that. We don't want to be prejudiced against people's faith or their communities. So if patients come to us and they want prayer, we're happy to pray with them, and we see that it creates a bond. It creates something in both of our relationship on both ends that's really special and valuable.
Dr. Merrick, close us out. So you run a big-time physician medical practice that is of significant renown. What was it that came to your attention about this situation where you said, hey, we're willing to invest in this? Because the level of commitment, it seems to me, is pretty significant in that you're not nickel and diming Dr. Phillip on what they're doing. And there's a little bit of a, throw the long ball feel to this. How much freedom does he have, and what's the expectation as it comes back to the decisions that you're making, kind of dollar and cents sort of things?
He has complete freedom provided he creates the results that he's doing.
Yeah, there you go.
So, we're a results-oriented group, and, the data that we've seen through the Breakthrough Care Centers shows that it's a better quality of life for our frail seniors. It's a much lower cost burden to our payer, our government, and it's when I recruit doctors to our organization, I tell them we're going to give you the influence and opportunity to practice great medicine. Looks like Dr. Phillip has a nice opportunity here to present his, it'll remain to be seen what this influence results in, but I think our goal in being here is just to share that investing in technology and healthcare providers, physicians, advanced practitioners, nurses, healthcare is going to be a people, local business forever, and I think one of our biggest barriers currently, as we're seeing the independent doctor, the practitioner is becoming extinct. Rapidly, and that is to the detriment of our patients and the community that we serve. Every place shows that when physicians work for a hospital versus for their patient, quality goes down and cost goes up. What we ask for is just an opportunity to compete and provide services. An example is I have two partners trained at the Cleveland Clinic who do robotic cancer urology surgery, and they can't do that in an outpatient setting, which is lower cost, safer, lower infection rate, because it's not reimbursed. It's illogical to take a healthy person who just happens to have a bad hip and bring them in the Petri dish, which is the hospital. There's a role for hospitals, intensive care services, rural areas, teaching institutions, but in many of our communities, there's way too many hospitals that are overbuilt. They compete for services with one another, and they don't bend the cost curve as is required of us. And so thankfully, our goal at DuPage Medical Group has really been to teach physicians the responsibility of stewardship, and that yes, you have to take care of that person and be the trusted advisor on the other side of the exam room and the operating room table, but you have a broader responsibility to the system as a whole because, quite frankly, you can help us support good medicine, but it's our job to fix the system. It's not your job to fix the system. It's your job to support people who can provide answers, and that's our goal.
That's great. Well, for each of you, thank you very much. We really are grateful for your energy and your attention and the ways in which you've encouraged us. Let's continue this dialogue, and I know that we can continue to be the beneficiaries of the wisdom that you've provided and the backgrounds and your experience. So thank you. At that, the meeting's adjourned.